This topic is hypovolemic shock. I know shock and types of shock can be overwhelming, but let's break this down and I know you'll get it. The name of this tells us a lot. Hypo, low. Volemic, volume. Low volume. The client has had fluid loss, and that results in decreased intravascular volume. That means decreased perfusion of blood and oxygen to the tissues and organs. Decreased venous return, decreased cardiac output, and increased systemic vascular resistance. This can be life-threatening. Let's take a little bit closer look at this using the illustration. You can see in this illustration what's happening with the body during hypovolemic shock. Less blood is returning to the right side of the heart through the superior and inferior vena cava. That means decreased central venous pressure. That right side of the heart doesn't have much blood, so it doesn't send much blood to the lungs, resulting in decreased pulmonary capillary wedge pressure. That results in less blood being pumped out of the heart, decreased cardiac output. Now, the body is always trying to compensate. It starts to notice that there's less volume, so it starts to vasoconstrict, increasing that systemic vascular resistance. By doing this, it makes the pumping of the heart more efficient by getting the blood where it needs to go. So how could this client have lost volume? Hemorrhagic reasons, bleeding, internal and external bleeding. Internal bleeding is that bleeding we can't see, maybe GI losses or a spleen injury. External bleeding is that bleeding we can see, the bleeding from a traumatic accident where they have a wound that's open and bleeding, or a nosebleed. And then clients on anticoagulation therapy. These clients may have an injury that for another client isn't as serious, but because they have inadequate clotting, they could lose large amounts of blood, resulting in hypovolemic shock. Then there are non-hemorrhagic ways a client can lose volume, like dehydration. And there's a couple different ways that a client can become dehydrated. Through GI losses, like in diarrhea or emesis. In renal loss, through osmotic diuresis, as seen in uncontrolled diabetes and in DKA, and in diabetes insipidus with lack of ADH. There's skin losses through burns and heat stroke. And third, spacing. This is when a fluid shift occurs, maybe from a crushing injury. The volume goes from the intravascular space to the extravascular space. And massive vasodilation. Now let's talk about the clinical features of hypovolemic shock and how those fit into the stages of shock. Because of hypovolemia, the client will have hypotension. The body will react with tachycardia and tachypnea, and eventually electrolyte imbalances. Due to decreased cerebral perfusion, there'll be changes in mental status. The client may become anxious or dizzy or confused. The kidneys will compensate with oliguria, and there will be decreased peripheral perfusion, with weak pulses, eventually absent pulses, and then cool, pale, clammy skin. Now let's talk about how those clinical features fit into the stages of shock. During the initial stage of shock, we might not even notice that the client has started to go into shock. The body starts to kind of see something's going on and starts slight vasoconstriction. We might see the heart rate elevate just slightly, and the client may become anxious. The compensatory stage of shock. This is where we start to see the body's reaction to hypovolemic shock. The sympathetic nervous system notices something is going on and starts to react. It starts to compensate. Sympathetic nervous system neurotransmitters are sent, and the cardiovascular system starts vasoconstriction. The body starts to compensate, and we start to see the clinical features. The kidneys will respond with oliguria. They're going to decrease urine output and increase water reabsorption. So the clinical manifestations we see in the compensatory stage include, due to that continued hypotension and the cardiovascular system reacting, we'll see tachycardia and tachypnea. Due to shunting the blood and oxygen to the core, the head and the heart, we'll feel weak distal pulses and cool skin. The client will become more confused or potentially more nervous. If treated in this stage, the body can recover. In the progressive stage, the compensatory mechanisms start to fail. The vital organs become hypoxic, and the less vital organs become anoxic and ischemic. This becomes life-threatening. The body can only tolerate this for a short time before it goes into multiple organ dysfunction syndrome and permanent damage. These clinical manifestations in the progressive stage include continued hypotension, continued tachycardia with arrhythmias because of those electrolyte imbalances. The peripheral pulses now are absent. They've shunted everything to the core of the body. And the client starts to feel feelings of impending doom or loss of consciousness. And then finally, the irreversible stage. Too much cell death and tissue ischemia has occurred due to lack of oxygen getting to them. Vital organs have extensive damage due to multiple organ dysfunction syndrome. Ischemia and necrosis of organs and tissues has occurred, and then eventually death. We want to intervene as soon as possible to stop the progression of shock. If you notice that your client is starting to show signs of shock, start the interventions. Our interventions can include fluid resuscitation. The type and the amount of fluid used may be different for every client. Crystalloids are used, like 0.9 normal saline and lactated ringers, and colloids, like albumin. And if the client needs blood, you might have to infuse blood products, like packed red blood cells and plasma. You'll provide supplemental oxygen to the client. This can be with a nasal cannula, a mask, or a non-rebreather. Any blood that's moving through the body, we want as much oxygen on it as possible. We might also have to prepare the client to be intubated. As the client goes into hypovolemic shock, you'll want to put the head of the bed down and their legs elevated. You don't want the head of the bed any higher than 30 degrees. This will allow gravity to help us bring that blood back to that core. It increases venous return and it pushes blood back to that head and to that heart. We may also give the client vasopressors and inotropic agents. We will continue with monitoring for this client. There will be serial lab draws with hematocrit and hemoglobin, lactate levels, and electrolyte levels. We'll be doing hourly intake and output. This will give us a good idea if those kidneys are continuing to be perfused. These clients will be on continuous cardiac monitoring to watch for those arrhythmias. We'll also be monitoring their vital signs and their level of consciousness. So remember, hypovolemic shock, low volume, hypo-low volemic volume. Whatever's in the body, as far as volume, the body wants to hold on to and use it to get to the heart and to the brain. Keep up the good work. I know you got this. I'm proud of you.